Welcome, everybody. We're just going to give a few more minutes and we're going to get started. Okay, I see the ticker going up. Welcome, everybody. We're just going to give it a couple of more minutes and then we'll get started. Okay, I see the ticker going up. Welcome, everybody. We're just going to give it a
Might have been audio on YouTube.
I'm used to hearing that I sound like a broken record, but that was unusual, even for me. Sorry about that. I'm used to hearing that I sound like a broken record, but that was Okay, I think I figured out what was happening. So we're gonna test it again and give it one more minute. I just want to welcome everyone who's joining us, and we're gonna get started shortly. Okay, I think we're ready to get started. It's 5 after 6. I think we're gonna have people rolling in, but why don't we get started? Because we do have so many of you with us today. I'd like to ask Dr. Gonzalez Cruz. There we go. Thank you. Okay, terrific. So welcome, everybody, and thank you all so much for joining us this evening to hear our esteemed panel of experts discuss what does science say, to explore the scientific evidence and how safe sending our kids back to school will be this September. And this is sponsored by Back to School Safely New York, a group of parent advocates. So over the past weeks and months, one of the key local and national debates has been how to safely send our children to school this fall. Everywhere I go, it's the conversation every parent and teacher is having. And we know that our children learn better in person. We know that keeping our kids at home isn't great for their well-being. We also worry about our children getting sick, spreading the virus to family, spreading the virus in school and in our communities. In New York City, parents are being asked to make a choice between an all remote and a blended option that combines some days learning remotely with some days learning in a school building. The current DOE survey is asking us to make that decision by tomorrow, August 7th. Both options seem to present different kinds of risks. Opinions on what makes the most sense seem to vary widely. So tonight, we'd like to focus on the facts. What are the risks associated with these two choices? Our panel of experts can help us wade through the research and hopefully make a more informed choice. Before we start, some housekeeping notes. Tonight, we'll hear from each of our panelists, and then we will have a question and answer period. We've gathered questions from many of you already, which we will ask our panelists to discuss. On your screens, you will see both a chat and a Q&A feature. Please feel free to use the chat feature to communicate with each other. We ask that you hold your questions for the question and answer period. At that time, we will monitor the Q&A and try to get to as many questions as possible. All questions entered will be visible. If you see your question already listed, we encourage you to upvote it rather than repeat it. And we appreciate all of you holding your questions until the end. Okay, so we have with us tonight Dr. Danielle Ompad. Dr. Ompad is an infectious disease specialist and an associate dean for education and associate professor at NYU's School of Global Public Health. Dr. Ompad worked on developing the plan for the safe reopening of NYU. Welcome. We also have Dr. Caliris Salas Ramirez. Dr. Salas Ramirez is a neurologist and distinguished medical lecturer at CUNY School of Medicine in the Department of Molecular, Cellular, and Biomedical Science. Dr. Salas Ramirez brings a wealth of expertise on the social and emotional impacts on the developing brains of young children. Dr. Salas Ramirez was also a crucial organizer of this event, so thank you for that. We also have with us Dr. Jorge Gonzalez Cruz. Dr. Gonzalez Cruz joins us from the City College of New York, where he is a presidential professor. Dr. Gonzalez Cruz is an NOAA CREST Professor of Mechanical Engineering and the founding editor of the ASME Journal of Engineering of Sustainable Buildings and Cities. Welcome. And last but not least, we have Dr. Cristina Gonzalez. Dr. Gonzalez is a physician scientist taking care of adult hospitalized patients at Montefiore Medical Center. Dr. Gonzalez conducts health equity research, specifically focused on designing interventions to enable providers to manage their racial implicit bias in encounters with patients, thereby striving to achieve equitable outcomes for all patients. In addition, we have artist and education activist Tamara Gayer, who was crucial to getting this panel organized, monitoring the chat and Q&A. I would also like to thank education activist and marine biologist Rayhan Mehran for her critical help in developing the framework and content for this panel. And we are so pleased to have Jocasta Evans Laura, an elementary school teacher in Brooklyn, New York, who will be translating the panel into Spanish in real time. And I'm Rashida Abouala. I'm director of the Relic Harwitz Foundation and have a background in government and system reform and social research. I'm also a parent of a public school student and a proud graduate of New York City Public Schools. And I'm honored to be here tonight to help New York City parents and teachers gain insight into the science behind safely getting back to school this fall. Okay, let's begin. Our first question. What do we know about the transmission of COVID-19? How does this inform the thresholds being used to determine whether school buildings should reopen and what safety protocols they should adopt? For example, the 3 or 5% new infection rate being used, keeping children 6 feet apart, and so on.
So I think that's to me. Thank you for having me this evening. I really appreciate all the people who are tuning in. So let's talk a little bit about COVID transmission. So here's what we know for sure. COVID is transmitted through droplet form. So that means that if I cough and you're within 6 feet of me, I can expose you to the virus. Now, exposing you to the virus doesn't necessarily mean that you're going to become infected, but it definitely increases your chances of becoming infected. More recently, we've started to see some data that suggests there could be aerosol transmission. So what's the difference between aerosol and droplet? Droplet is basically bigger. So droplet is is they're slightly bigger, and aerosol, think about what happens when you use an aerosol spray like hairspray or something like that, and it's a very fine mist. So the smaller particles are what we mean by aerosol. So there's some suggestion, and the WHO has actually recently agreed that there's mounting evidence that there's aerosol transmission. So what does that mean? That means that 6 feet is probably the minimum distance that we should be using. And in some cases, we may want to think about longer distances between people. We also know that COVID can live on surfaces, right? So there's my favorite public health word, which is fomites. So fomites are basically, I cough and then I use my computer and there are fomites on my computer. When I was little, we called it the cootie touch. But essentially, it's the idea that the virus can live on surfaces and it's transmittable. So what that means is I sneeze on my computer, I type away, you know, my child comes and uses the computer after me, they touch the computer, they touch their face, whoops, you know, we have the potential for transmission. So those are the major modes of transmission that we're concerned about. We have seen in the literature that there is fecal oral transmission, or not, well, there's fecal oral transfer, meaning that there could be virus in your mouth, but also you may be shedding it when you poop. And so we know that washing hands is really important, both for the aerosol and the droplet transmission, but also after you go to the bathroom. I mean, that's something we should all be doing, but we know that kids sometimes forget to do that, right? And even some adults. So in terms of transmission and thinking about opening the schools, the things we're going to be concerned really about are that droplet or aerosol transmission and the transmission that can happen on surfaces, right? And so that's why masking is so important. If I mask and you mask, we really reduce the likelihood of transmission. It's not 100%, but it's lower. And at this point, lower is what we're going for. It also means that socially distancing is really important. Now, the extent to which people can social distance is basically based on the space that they're in, right? So whatever the size of the classroom or the cafeteria or the multi-purpose room is going to determine the capacity of the number of people that can be in that room safely. But we also know that kids really like to interact with each other. And so I think it will be challenging to get kids to be very careful about staying away from each other. And to some extent, I'm sure that that's going to be a challenge for any teacher trying to manage the classroom. Not only are they trying to teach content, but they're also really trying to keep the kids safe. And the kids aren't doing anything other than what kids would normally do. And we're potentially setting them up for having a little bit more conflict with the teachers and staff that are working with them, just because, you know, kids like to touch each other. I don't know what it was like. So I don't have kids, but I know when I was a little kid, I was constantly being told, keep my hands to myself, right? And so that is going to be a refrain that we're probably going to hear a lot. It also means that keeping the classroom surfaces disinfected are going to be really important. That's going to take a lot of effort. And not just once a day, but probably throughout the day, depending on what the students are engaging in. So in terms of thinking about this and going back to the classrooms, I think to a large extent, this is going to be driven by what the epidemic curve looks like in the city. Now, generally, we think about the epidemic curve as one curve for the city, so one graph for the city and the number of cases, but we do know that transmission has varied across the boroughs and across neighborhoods, with some neighborhoods being more affected than others, which means that if we want to have effective policy, it really needs to be focused on what the particular needs are of that community. So, for example, at the beginning of the epidemic, we saw a huge number of cases in Elmhurst and maybe not as many cases in other neighborhoods. So what needed to happen in Elmhurst was going to be different than what needed to happen in other parts of the city. So it really is like clothing, one size does not fit all when it comes to pandemic policy. So that's just something to keep in mind. Yeah. So is there anything I forgot?
Thank you. I think that covers it.
Okay.
So let's, get into some of the research, at times conflicting research. The South Korean CDC, published a study that suggests that while children under 10 do not spread COVID-19, those ages 10 and over spread it as effectively as adults. Researchers in Chicago published a paper last week finding that children age 5 and under with mild symptoms of COVID-19 have 10 to 100 times as much virus in their noses and throats as older children and adults, and may be major contributors to the spread of the virus. And, that was published in JAMA. Some research shows that very few children get COVID. Yet other research shows that this can vary widely. So can you help us reconcile the varying research that has been published on how children contract and transmit COVID-19? And then furthermore, how does the virus impact children in the short and the long term? And what are those differences by age? Dr. Cristina Gonzalez, would love to hear from you on this.
Great, thank you. So it's hard. I can imagine it's hard to try to hear all these conflicting reports, right? One week, one study says this, we wear masks, don't wear masks, we should wear masks. And, but the one thing that I think must be hard is to recognize how much just a brand new disease this is, right? Now, I've been a physician for 16 years, and I know that's not forever, but it's not just a little bit. And it's like nothing I've ever seen before. And we had a really bad flu epidemic for H1N1. Some of you may remember the really bad flu season we had. It was like 2009, 2010, that winter. And that was scary. And this was just infinitely worse than anything I'd ever imagined. And I say that to say that it's because we didn't know, right? There I was feeling pretty experienced as a doctor, taking care of patients that had a brand new disease that nobody knew anything about. And so the research is catching up at the same time, right? It's being done at the same time. There's that expression about building the plane while you fly it, right? And this has really been, and people are working extremely hard. It's not a criticism of the researchers, the doctors, everybody taking care of patients. It's brand new, and we had to help people at the same time. And so I think it's part of it is that we don't know the reagents, like the chemicals that were used to do the testing for the science in the South Korean study. We don't know the different variables or how they tested, et cetera. But I can say that looking at the study in JAMA, which is a very respected medical journal that was just published out of Chicago, the data show that really little kids are similar to adults in terms of how they're spreading it. They do have a lot in their oral pharynx, right? So this area, like your nose and the back of your mouth, but they have just as much. And so you're thinking, well, I don't see kids getting that sick compared to adults. And that's what happens with the immune system. So I know I said COVID is very new and there are things that we still are learning about it, but children's immune systems are known to be not as developed as adults. So a child may get the same disease that their parent gets, and maybe have a little mild illness, and the parent gets very sick. Hepatitis A is just a type of virus that is very common for this. Little kids will have a little diarrhea, stomach ache, and the parents can have their livers go into just terrible failure and need to go to the hospital. And so COVID is a little bit like that. Kids walk around, they feel a little, is it just the sniffles? We don't know, but the parents can get really sick. And so I think that also contributes to the conflicting nature of the research, because we're not testing everybody, right? We're testing symptomatic people, and kids aren't as often symptomatic. And so I think that at this point, because COVID continues to show more and more dangerous aspects, I think it's important to have an abundance of caution And because the children are spreading it. And even when this first started back in March, when we were at the hospital constantly having meetings, constantly trying to figure this out, our epidemiologist at the hospital said that children are super spreaders in general for contagious diseases like this, meaning that they're okay. And since they're okay, they're going to play, they're going to run, they're going to hug, they're going to kiss, even if they have the virus. And that makes them a super spreader, meaning they spread it to a lot of different people. Whereas as a grown up, I'm going to feel kind of and stay home, because I'm going to be sicker. And so that's a known fact, and COVID is expected to act like that. And then on the impact of the virus on children in the short and long term, we've seen that some children hardly get sick, and some have that horrible disease, that inflammatory syndrome that leaves them in the hospital, and some children are dying. And so it's a smaller number of children, yes, thankfully, but it's still a big spread, and I think it's too early to say the short-term impact, and definitely too early to say the long-term impact, right? The disease has only existed for a matter of months, and so we can't say a long-term impact. But I would encourage us, as we're thinking about short and long-term impacts on children, of COVID on children, is to also remember the short and long-term impact of COVID on children as it relates to their families. Right? And the short and long-term impacts of losing a parent and losing a grandparent and losing your caretakers, whomever they may be. Or what we're seeing, which is devastating, in addition to people dying, is relatively young people and older people, but relatively young people also getting chronic, like long-term problems from having COVID. So they can't breathe because their lungs reacted and got sick for the long term, even once they got better. Their hearts don't pump the way in the strong way your heart is supposed to pump. So that I think in thinking about the impact on children, we have to also remember the impact of losing family and losing or having a parent then with chronic illness, or a caretaker with chronic illness, which is an increased risk as you have more exposure. And I know Dr. Ompad has thoughts to share with us.
Yeah, I just want to say, thank you, Dr. Gonzalez. And I think what stood out to me is an abundance of caution, and that both studies could have an element of truth to them. And we will only know with more extensive and additional research, and that it takes time. Dr. Ompad, I'd love to hear your perspective on the widely varying research.
So I would just like to co-sign what Dr. Gonzalez has said about this being new. So we've known about COVID since December 31st, 2019. So we're talking 8 months and 1 week that we have known about this. So any opportunity for us to look at long-term consequences, the longest term consequences we could be looking at is 8 months and 1 week, right? Because that's how long it's been around. Now, there are other coronaviruses that we know about, like SARS and MERS. However, COVID-19 actually acts differently than SARS and MERS. Those were a little bit more delimited, smaller outbreaks. They weren't pandemics in the same way that COVID-19 is. And so just keep that in mind. The other thing is that when you look at these studies, typically in epidemiology and in public health, you'll see varying estimates of what the risk is, right? So you'll see one study says kids are transmitters, another study will say they're not transmitters, some will say we're not sure if they're transmitters. This is pretty typical, and the reason why this happens is because people are doing studies in different settings. They may be asking different questions. They may be at a different time of their epidemic. They may have recruited people who are earlier in the infection versus later in the infection. So and because it can be a little bit difficult to time when somebody got exposed to when they actually got symptoms, it becomes very challenging to kind of pinpoint the extent to which kids may be transmitting. So I agree with Dr. Gonzalez that we should probably err on the side of caution until we have more evidence to suggest one way or the other. I also do agree that kids do tend to be little transmitters. They're adorable, they're sweet, but they're also, like I was saying before, they like to touch things, they like to be around people. They like to touch each other. It's kind of the natural course of childhood. And to some extent, putting them in situations where they're doing that with other people who have different experiences in the outside world and maybe exposed differently to COVID, we should think very carefully about that and how we can manage that in the classroom. So I agree that I would be very cautious right now. I'm not saying that the schools can't open, but the way that they need to open, as I know we're all struggling with, is how can we do that safely so that you get the benefit of that face-to-face interaction with kids and teachers and staff, but also are able to protect the kids and the staff and teachers.
Thank you, Dr. Ompad and Dr. Gonzalez. That's very helpful. I mean, you know, I think one of the things that we still need to understand is that this disease has had a disproportionate impact on communities of color, like many other diseases. And so, you know, in New York City, over 65% of New York City public school students identify as Latinx or Black, as do many of the adults who work in our public schools. And some estimate that over 80% of paraprofessionals, food service staff, custodial staff, and school safety agents identify as Latinx or Black. And so we know that communities of color have been disproportionately adversely impacted by COVID-19. What do we understand about the reasons for the disparate impacts of COVID-19 on these communities? How have these impacts played out in the lives of the communities? And, you know, how should this reality weigh into the New York City school reopening debate? Dr. Gonzalez?
So let me take those one at a time. And so in terms of what do we understand about the reasons for the disparate impacts of COVID-19 on communities of color, I want to be very clear and state that there is nothing inherently wrong, right? Or prone to illness of Black and brown bodies. There's not a genetic reason. There's not a biological reason. It's not at the individual level, and I don't want people to internalize, like to think about it that oh, it's something like we're more likely to get sick and things like that. It's not that at all. We are more likely to get sick, but it's not because there's something wrong with us. We're more likely to get sick because of structural factors, right? Structural racism, segregation. And so people often think, oh, but New York City's, you know, such a diverse city. And it is such a diverse city, except we live in little pockets. We live in little segregated pockets. Of course, I'm generalizing, but it's a lot. Like 78% of New Yorkers would need to move for us to not be segregated. And so it's segregation at the as Dr. Ompad was saying, the neighborhood level, and each community is different and has its different needs. And that's why I can't emphasize enough how much I agree with your comment about one size does not fit all, right? And that we need to tailor our policies for the communities affected. And so it's the structural factors that lead to diabetes and obesity and heart disease that are more prevalent in Black and Latinx communities than in white communities, for example. And again, that's not a genetic thing. It's the way that communities have been structured over time through zoning and redlining and other things, other policies that lead to segregation. And so living in that community under that kind of stress actually increases what's called your allostatic load. Your allostatic load is like it's like a constant stressor. It's just this constant feel inside. It's a chemical reaction. But it's this increase kind of revved up all the time. If you've ever maybe been working extra, or maybe picking up some extra shifts, or you have a newborn and you're sleep deprived, and you're more likely to get sick, right? Or catch a bad cold. And that's what's happening to our communities on a chronic, kind of consistent level. And I can tell you this because when about 10 years ago, the H1N1 epidemic that I mentioned, that was about 2009, 2010, the same thing happened. The exact same thing happened. And it was written about in the medical literature, and I guess it didn't make it out the medical literature. I was still a pretty young doctor, so I don't really know what happened, but it was all of the things they predicted we should do, we should have done, and we didn't to prevent this type of disparities and the onslaught of like sickness and death in our communities could have been prevented, and it wasn't. And so now it's out of the medical journals, right? Everybody knows what's happening. It's all over the lay press. And so now we need to learn, and it's not going to change. We haven't changed the structural factors. We haven't changed the amount of stress that communities of color are under. We haven't changed the resources at the hospitals. If anything, actually, the funding that was sent to the different hospitals across the state from the government, from the federal government, actually was worse. It made it worse because it was based on Medicare payments and not actually on COVID sickness. And so like Queens and the Bronx, for example, got much less than they should have for how many patients we were taking care of. And that matters for thinking about how the impacts play out. Right? So we're getting sicker. You've got the long-term effects that I mentioned, your heart, your lungs, other long-term sickness. People are losing family members. People are losing jobs. And then we have the fact that the hospitals are already overcrowded and are already running under-resourced. And that's going to make it harder. God forbid we have a surge, right? If we open up schools for the communities that are already being disproportionately affected, right? The communities that are getting the worst care, the worst outcomes, not care, the worst outcomes already from COVID are just going to keep getting the worst outcomes. So this time we're not building the plane while we fly it, right? We know what's happening. We know what's going to come. We have to be proactive and make sure that we account for this. And so the reality weighing into the New York City school opening debate, when you think about this, some examples, we have to have lessons learned and we need to learn them quickly. So we cut down how many trains we're running, right? For some subway trains we're running because there were less people going into Manhattan because the city was shut down. And what that led to was crowded platforms in the outer boroughs, right? And so where was mostly, people of color who were essential workers had to go to work and were standing on crowded subway platforms waiting for trains and then being exposed to more disease. And the last thing I'll say is that the big picture of why it has to play into the New York City school like reopening debate is that we have to think about prevention. We haven't fixed the problem. We haven't fixed the structures. Even if you account for like the obesity and diabetes and heart disease disparities that exist, and they're saying, oh, that's why you get more COVID. It's actually way more than we would expect from the existing differences and disparities that are already in health. And so every measure possible needs to be taken to prevent kids from getting it, because we just talked about their super spreaders, right? From the staff from getting it. People also live in multi-generational homes, right? We've got much more crowded housing in New York than other parts of the country. So you've got 3 generations living in the same home. So your cute little child is going to infect their grandparent or their parent. And and once you can't isolate in a small home with 1 bathroom, right? In a small apartment, you just can't do it. So every measure possible to prevent people, like children and adults, getting it in the schools and in transit. This isn't just for the Department of Ed to decide. We've got to figure out what to do with the transit system and how to have less people on a bus or in a subway car. And I think that is an effort from a lot of different organizations. But I think that, as I mentioned, overabundance of caution. I love Dr. Ompad's statement about tailoring solutions to individual communities. And I can't stress enough how prevention is key.
Thank you so much, Dr. Gonzalez. I mean, I think the key takeaway is that the prevention measures should have been put into place from all the lessons learned from years ago. They haven't been put into place, and that this will continue to have a disproportionate impact on communities of color in New York City. Let's weigh this with the, sort of the counter argument in terms of well-being and children's well-being overall. The American Academy of Pediatrics released a statement that suggests the benefits of returning to school on children's overall well-being and social emotional development outweigh the risks posed by COVID-19, assuming community spread is low. Dr. Salas Ramirez, can you help us understand the importance of in-person school for the social emotional development of children of varying ages? And secondly, going to school with the recommended safety measures in place will require a drastic change to peer-to-peer and educator-to-student interactions. So with measures such as social distancing and mask wearing in place, will children's social emotional needs be met in school, especially for the young children?
Thank you for that question, and hello everybody. I just want to make sure that I let everybody know that I'm not a neurologist, but I am a neuroscientist and a developmental neuroscientist at that. I'm also a proud parent of a rising fourth grader that attends Central Park East 1 Elementary School, and I'm the CEC4 president. So I am deeply entrenched in these reopening plans as much as I can. So I'm very proud of having this panel of esteemed colleagues to help parents in this journey that we're taking. Schools right now have several ways to support social emotional learning. A couple of years ago, the Department of Education engaged in work with Dr. Mark Bracken at Yale, at the Yale Center for Emotional Intelligence, because they realized that children needed to understand their emotions and feelings more. And so you may be familiar with the ruler method that's used in schools that has a mood meter, and children have the ability to identify their current emotion or what they're feeling right now, and then engage in different strategies, whether it be mindfulness, meditation, talking to a counselor, peer-peer interactions, in order to get them to a happy place, right? And so mood meters are commonly used in schools, and this curriculum, the social emotional curriculum, has spread throughout the Department of Education. In addition to the mood meter and ruler, a lot of schools are using restorative justice practices to engage in or minimize some of the zero tolerance policies that a lot of schools had been engaged in. One of the things that we know is that with our large population of Black and Latinx students in the Department of Education, we do understand that a lot of our children are experiencing these zero tolerance policies, and they could be suspended for up to 180 days. And that policy literally changed a year ago. And there's high policing of our Black and brown children in our schools. And so these last couple of years, there's been a lot of reform in terms of how we're engaging in social emotional practices. In addition to the restorative justice practices, this last year, a lot of principals were trained in trauma-informed practices, which is a pillar that our chancellor has integrated into the reopening plan, because we do understand that a lot of children have lost family, have even had COVID themselves. And we have also experienced in the last couple of months the racial trauma that has been inflicted upon us in American society. And a lot of us have been triggered by the murder of George Floyd. And so a lot of things have happened socially, particularly in communities of color. Since COVID, there are other groups that have been talking about creating what are called healing-centered schools, and sort of taking into account all of these different methods, but ensuring that schools have the support. So one of the things that we know is that all schools may, some don't, have counselors and social workers. Those counselors and social workers are heavily taxed. Sometimes in a school, you can have a counselor or social worker that is servicing up to 400 or 500 children. And that is just absolutely unacceptable. And so again, we want to focus on social emotional learning for students. We want to focus on social emotional support, but unfortunately our schools are not staffed with the appropriate people. So what are some of the concerns going back to school? Our kids are being told that they need to socially distance. Our kids are being told that they need to wear masks for the 5.5 hours that they're going to be in school. Our children are also, they will no longer have recess. They will actually have what's called an instructional lunch, which means they're going to engage in instruction while they're eating to keep them at their desks and from talking to each other. And so even though our children need that contact and need to be in school for those social interactions and that social cognition to develop, we have to really consider what is the cost. And so, are we going to send our children to school so that they can be policed and have restricted behavioral interactions with each other? And how is that going to have a long-term impact on their social cognition? So one thing that's incredibly important at these developmental milestones are those social interactions. Children in early childhood programs, so from 3K to second grade, it's absolutely critical for a child to be able to understand what their position is within social structures. Right then is when they're understanding what authority is, how to regulate their bodies, how to be in tune with their emotions, so that they can continue have this continuum of understanding, who do I negotiate things with, who is the authority, and how should I engage in what we consider to be typical behaviors with social interactions. I would highlight that adolescence is another really critical period of social cognition. And so we really believe that adolescence is at a continuum of childhood, in where it is that transition from childhood to adulthood. It's when I learn, or when we learn as human beings, who I am within this world and what purpose do I have. And so it's absolutely necessary and important to have these social interactions. So I am in a room with a teacher, and they have a mask on. And one of the ways that we as human beings communicate is by looking at our facial musculature. So every single basic emotion, and we have 6 basic emotions. And if you haven't seen Inside Out, I would recommend it. Disney's really good at teaching us about basic emotions. But those 6 basic emotions have very specific musculature that we all recognize and that we all understand in order to understand these social interactions. Just by limiting this facial area, we really don't understand what is that's happening. I also have to highlight that these are the limiting factors with general education children. We also have to understand that we have multilingual learners in our schools. We also have children that have learning differences in our schools, or children that require IEPs, children with sensory sensitivities that cannot wear masks, and that will then not be allowed to be in school. The chancellor has released guidance saying that any child that does not wear a mask will be sent home and will be automatically be put in remote learning. So there are some really significant concerns. The other concern that I have is, what are we going to do if schools open and 2 to 3 weeks later we see an increase in COVID cases and then they have to close again? We're now then inflicting more trauma on these children. We're changing their routines once again. We're changing what their day looks like. We have to explain to them, why is it that we're going back home? And then the fear gets heightened again. Is it going to be the same way as before? And so right now, most of us have established routines in our homes with our children, and transitioning them into a couple of more months of remote learning as we develop a more concrete plan with better safety measures could be the smartest thing that we can do in terms of their neural development. So.
Thank you, Dr. Salas Ramirez. It's fascinating, and you bring to light all of the complicated variables that come in, and all the various, between the lack of staff in school buildings, and we're getting some affirmations from our chat from school personnel who work in OT or in other areas that are related in terms of the impact of no recess, the impact this will have on children coming of age, the impact it will have on different learners. And these are all, and then especially the issue of re-traumatizing kids is clearly not discussed enough. So thank you for that. Let's pivot a bit and, try to understand a bit the state of our physical plants in our schools. We have learned recently that it is more likely for COVID-19 to be transmitted via airborne particles rather than surfaces. And so the DOE has committed to deep cleaning all school buildings daily. And we've heard that HVAC and ventilation systems have been or will be upgraded to meet CDC requirements. What is required from a technical standpoint to have safe air in schools? Is it possible to clean air of COVID-19 particles? And if it is, what would it entail to do this across every New York City public school? And this question is for Dr. Jorge Gonzalez Cruz.
Yeah, Rashida, and thank you, Khalidis, again for inviting me to this great, very enlightening panel. So on the question, if we do decide to send our kids back to school, and of course our teachers and staff to teach them and support them, then the question is, what are those requirements that may be needed to make that possible? So that's a very important, great question, and to that degree is that we're sending our children to an indoor space. We do have weather and climate in New York City, and we tend to, in all cases, we tend to control that indoor environment. So we will have everybody somehow interacting into that indoor space. So a key question that as a parent we may want to ask is the mechanical system safe for our children or the staff to be in those spaces? And that's a hard question for a complex system such as New York City. And part of it is that having a very basic understanding about how HVAC systems work. They do maintain the indoor environment and also the air quality. So there are two key variables there that need to be kept in balance, what we call thermal comfort, temperature and humidity. If it's too hot, of course, we are uncomfortable, we cannot learn, and we may get sick, and vice versa, if it's too cold. And that's why we have the mechanical system to provide human comfort levels. Now, the question is how my school district is being equipped. Do we have a central system versus a Windows operation? What about heating or cooling system? And that's crucial. So most schools will probably have, if they are designed and built in the last 30 years, what we call central air conditioning systems. So the way that this system works is that there is a mechanical ventilation providing air, whether it's cool or hot, to the environment, and a good portion of that air will be recirculated. I said a good portion, a fraction of that is actually thrown out and fresh air is coming in. So there is interaction, even with a mask and personal equipment, interaction of everybody's breathing. Eventually, the air that we expel will go into that environment. And there is no certainty how long this virus really, what's the lifespan of this virus. There's a lot of questions about this. Is it enough to, when the air is recirculated back, to keep the virus still alive? Or the concentration of the virus is still too much for the environment. So we need to have a clarity on the proper ventilation. Now, having central systems, it is an opportunity to clean the air because that air will be returned through a central system. At that point, then we can deal with filtration of the air. And that filtration, we do have the capability to filter the air, and there's standards about that. It's the American Society of Heating, Refrigeration, and Air Conditioning has established standards for this filtration. We call MERV 13, equivalent to HEPA systems altogether. We don't know exactly whether it's going to be a MERV system 13. 13 stands for controlling particles that are between 0.3 or larger. And there is debate about the size of the particle too, but if a typical virus will be transmitted through some combination of the virus itself and some water system that is coming from the body, typically it's going to be about 0.3. So MERV-13 is a good standard recommended by ISRA to keep the indoor spaces properly filtered. Now, the issue is that not all schools are equipped for installing filtration system at MERV-13 or not. So that needs to be upgraded. And my hope is that the school districts are looking into this, but as a parents, we want to ask that question: is the system being upgraded to have the best capabilities to filter the air? Now, at the same time, we're going from the cooling season to the heating season. So assuming that the school have a central air cooling system and we can control the air, and we have a couple of weeks to upgrade the system before we go back to classes, and maybe a little bit hot outside, so we need cooling. The big challenge is on the heating, because the infrastructure of the whole Northeast is mostly what we call radiant heating, which is hot water passing through a system panel. We have a boiler, hot water, and then there is very little ventilation, very little. And that is a challenge because our heating season is much longer than the cooling season. So we will have to bring some ventilation. We need to make sure that our classrooms are properly ventilated, and we have X amount of people, which we know how much we need in terms of how much people the space can occupy for a given ventilation rate. Most ventilation systems are designed to remove the air 1 time per hour. We probably will have to go about 3 times that value, or reduce the number of people per space. So I will think that most school districts will know about these guidelines. I'm a little bit aware that at least at the university level, we're looking into those, but that doesn't mean that our infrastructure is equipped to handle this issue. So the issue of proper ventilation in the heating season is the most concerning. And we want to ask that question: is the school really ready to provide proper ventilation and indoor air quality meaning filtration in both seasons, the cooling and the heating? Is it okay once we do decide that the school is may open? If not, the school should not open. I mean, that's a short answer. It should not open if the school doesn't have the infrastructure to be upgraded or outdated, because it was just not designed to be outdated for the challenge in that case. But if it is, then it's possible. Now, in all worst scenario, in the heating season, we need ventilation. The old-fashioned solution, open the windows or teach outdoor, still valid, right? 1800s, that was a proposed solution because of that reason. The outdoor represents, or the equivalent to the high ventilation from bringing fresh air, provide the possible safest environment. So in occasions, we may be able to bring some fans and to supply additional ventilation in the heating season. And if so, we will have to compensate by adding heat into the classroom. So all these things are necessarily, so I would suggest that, and as a parent, I had 4 boys, and they went all to public schools, and is to ask the question to the school district as part of the reopening, that are this all HVAC system being properly inspected? What type of cooling and heating system our school and classroom will have? Do we have appropriate filtering, MERV-13 or better, or equivalent HEPA system? Do we have mechanism to provide additional ventilation and filtering as needed? And fans are always an option for it. And of course, all of this will depend on we are even more careful in providing maintenance and monitoring the performance of the system. Do the school have the capability to monitor the performance? What about if one of these systems goes down? How soon can we? If the central system is not functioning, there should be no classes at all, under this condition, because that air will remain in the classroom, and the kids will be sharing with the teacher whatever air is being expelled. We don't know how long this the lifespan of this virus is at this point, and we're not going to know it in a very short time. And share information, be open about this. Prior, what was the system, what was done to upgrade it, how it's functioning during the pandemics as we go back to the classroom, and hopefully even after that, have we been, when we find a solution, if the system keep, the rooms have maintained proper indoor air quality all together. And if by all means we have to bring the student to class, and then the outdoor option is always there, and it's been a proven option as a worst scenario.
Thank you so much, Dr. Gonzalez Cruz. I mean, just to paraphrase, in the warm weather, if a school was built in the last 30 years and has a central HVAC system, it is possible to install filters to catch the particles, which we believe are consistent with other, particles that are of similar viruses. However, because in the Northeast we have radiant heat, there needs to be an additional air filtration system that is circulating the air 3 times an hour, when a typical air filtration system circulates the air once an hour. And then there's a complicated factor in these old school buildings too, where windows only open 6 inches and do not provide adequate airflow. And then in addition, there are buildings, and we've gotten some questions from parents on this, where the facade is covered to prevent asbestos particles from flying. I can't believe we are still talking about asbestos in New York City public schools, but it's still an issue. And we have mesh to prevent the particles from coming into the buildings, further impeding airflow. And so this is a huge concern, and your recommendation is that, again, consistent with the other experts on the panel, is that without excellent infrastructure, we will be recirculating potential virus particles in the air, and we will not be filtering them out. So thank you. That was really helpful, and we needed to hear that because there's been such an underemphasis on air quality in this entire conversation. So thank you so much for that. And I think we'll probably have more questions for you from the chat in the Q&A. So we're about to wrap up we have a couple more questions to wrap up the formal part of the Q&A, and we are monitoring the Q&A, and we want to get to as many of your questions. So we're going to move on to another question. And that is around the blended options and these pods. So, the DOE's blended option includes a hybrid of learning in person and remotely. How is that going to work in high school and many middle schools where students will be with different cohorts of children and unique teachers for each subject? In other words, a student may be in 5 or more different pods on the days that they are in the school building. For families with more than 1 child in high school, the number of potential exposures seem very high. And for families of young children who require childcare setting after school or when they're remote, those are several more pods potentially over the course of a week. So what risk does this pose, and what would be required from the schools and the childcare settings to do accurate contact tracing to prevent a surge in community spread? And so this question is for Dr. Cristina Gonzalez, and then we'll also hear from Dr. Salas Ramirez.
So it is almost hard to answer this because it's basically, oh please, excuse me. Always when I have to chat. So there was the, as I was mentioning earlier, how the children can be super spreaders, right? Because they feel okay, and then they're gonna be out and about and touching and breathing and things like that. it just makes that risk bigger, right? So every time you're near more people, then you have a chance to infect them. And so it just, everything I was saying earlier about how we need to think about preventing becomes even more complicated. And that's concerning because, you know, if you have all of those risks to begin with, and I can't, you know, Dr. Salas Ramirez was saying about how there's the social and emotional development of the children, and it made, just listening to her made me realize, yes, we are going to be asking like very difficult and potentially unrealistic things of our children at any age and when they're in school. And so I thought to myself, well, that's going to cause increased risk if you're moving around the pods and you kind of got up and about and a little bit of the feeling, and then you're going to have to sit back down, and then you're going to have more risk and more people and someone you haven't seen for a few days. And so that concerns me a lot. And I also brought to mind the fact that I'm not in any way an expert on the new programs that Dr. Salas Ramirez was mentioning about that are now replacing the zero tolerance plan from before, but there are lots of studies that show that there are racial disparities in the way that we discipline our children. And so Black and brown children are getting kicked out of preschool at 4. What are you getting suspended for at 3 and 4 years old? That's for another time. And so, but all of those racial disparities, right? Disparities are differences that are preventable and unjust, right? So every time we say disparities, we're thinking about things that shouldn't be happening. And so if you have racial disparities in the way you discipline children, and then that actually shows over time to have health disparities in young adult and adulthood, right? Because of the damage to their education. And so I'm really worried about thinking about what's going to happen with all these children that are supposed to be sitting down, and the bias that might lead to disciplining a young Black boy differently than you know, a young white boy or girl, and the effect on that just for not sitting down and for not staying 6 feet apart. And so I think that when you have these pods, everything that we've been saying, and the circulation, right, the childcare, the additional contact with more people, just everything we've been saying basically has an increase in a higher risk. And so all the things we were talking about, the effects on the children, but also the effects on the family, right, of potentially, you know, becoming an orphan, is a very real risk. I'm not trying to be alarmist, right? It's actually, there's already cases of this happening in Georgia, where they reopened schools. And so this is an incredibly difficult decision that I don't have to make, right? So I don't envy anybody's position. I just think that I just want to be clear that those are the risks that we're going to have to be weighing, right? And so, and then the other thing in terms of contact tracing, it's something, again, that the DOE can't do by itself, right? So, you know, what is the plan for, you have to have very good attendance records, and then what is the plan for the 14 days that they're out of school? And then the in and the out, and the in and the out is a whole class. Do you want to add anything else, Dr. Ombad, as the expert in this?
So contact tracing is a challenge, particularly when there's a large number of cases, because of the volume of people that you need to keep track of. Right now, Health and Hospitals is responsible for contact tracing in New York. And from a school perspective, if there's a case in a school, that's going to rely on teachers keeping track of who was where throughout the school day. So what Dr. Gonzalez said about keeping attendance and understanding who was in what room at what time, to identify who those children were who may have been exposed to a case. Now, it is challenging. You can't expect small children to be accurate in their reporting of who they touched, who they were, you know, close, within 6 feet of. Quite frankly, I'm not sure I could tell you what 6 feet looks like, let alone a child trying to understand, is 6 feet way across the classroom, or is it right next to me, right? So it really is going to rely on teachers knowing who was in the classroom, and also cooperation once those cases are identified, cooperations of either the case or their caregiver in terms of giving information to the contact tracers. That's been an issue throughout the country, that people don't want to say where they were and who they were in contact with, which is unfortunate because contact tracing is generally an effective form of epidemic control. It's something that departments of health have been doing for years. They do it with syphilis, they do it with tuberculosis. And so if we don't give them the information that they need to identify potential contacts, then the effectiveness of contact tracing is going to be limited. And so I think within a school setting, there's the added difficulty of trying to have teachers and staff keep track of where kids were throughout the day, particularly if they're moving around quite a bit.
Thank you, Dr. Ampad and Dr. Gonzalez. And yes, how are these different entities going to be? Are they going to be communicating with each other, sharing the lists, so on and so forth? It becomes really complicated. Another complicated issue is transportation. What is required in school buses, public subways, and buses to safely travel to school? And we know more vulnerable communities travel longer distances to work and school. And how should this be considered in the debate to reopen schools? So for this question, we'd love to hear from Dr. Gonzalez Cruz and Dr. Ampad.
Yeah, that's a great question, Rashida. And of course, the transportation, in terms of the environmental contact between the students as they transport in the buses all together, that provides an additional indoor environment. So there is an opportunity for that type of aerosol interaction altogether. However, the bus systems are equipped, are properly equipped for the most part with proper ventilation, and they do have the option of what we call 100% fresh air. So even tuning to be 100% fresh air, I believe, and again, this is not being proven because we're all in this environment, but it's most likely that the possibilities of spreading and contaminating between the students, as long as there is enough space, all right, it should be expected to be safe. However, that action needs to take place, meaning that all the buses need to be equipped properly with proper ventilation. It should be working very good and bringing 100% fresh air, no recirculation. And as we go in our automobiles, we do have that option, whether bringing the air from outside entirely or recirculating or a fraction of it. In this case, the system is to be set up in such a way. The next step is to spread to space out the students within the bus. So we're going to have to reduce the number of students that will be transporting, so there is no express of downwind. So there is no streaming between one and the other. There's enough distance for the virus to, if there is an active virus in the bus, to precipitate, and that will be about 6 to 10 feet between each student all together that are between downwind and upwind. So that arrangement, that logistics needs to take place. I will think that the school districts are thinking about this. It's not a hard solution and it's doable. So there's a little bit of hopes on that direction.
Great.
So
Go ahead,
one
Dr.
thing I'd like to point out is that not all students are going to school on school buses. So during my commute, I often see a lot of middle school and high school students commuting to their schools. And so I think what this question really highlights is the fact that opening up schools safely is not just an issue for the Department of Education. It's also an issue for the Department of Transportation. And so going back to what Dr. Gonzalez said about reducing the frequency of buses and trains and creating crowding on platforms has as much an impact on people who are going to work as it does on kids going to school. So I do think that that's going to be an important issue that needs to be considered, particularly for the kids who are allowed to go to school on their own. The other thing I will say is that it also highlights this important point that opening up schools safely is not just about what's going on in the schools, right? It's about what's going on in communities and at home, and the extent to which individuals within families are able to socially distance and mask as appropriate when they're going about their days. And so we really have to take a holistic view of what's going to happen. And I think that to only focus on what's going on directly in the school environment is going to miss what's happening when kids are at home or when kids are in transit. So it's really key to consider that as the plans open. And quite frankly, that means fewer kids in classrooms, fewer people in the school, if the schools are going to open at all, and vigilance on masking, which is going to be a challenge for all the reasons that have been discussed.
Thank you, Dr. Ampad. That is, I see that as a through line to everything that we're saying, is that it's so much more than just about the schools and the physical plans. So we have a lot of questions, and we have a lot of parents and caregivers and teachers eager to get their questions answered. But before we do that, we'd like to invite you to leave us with a final question or a thought. In all of the things that have been discussed or debated on a national and a local level, what do each of you feel are the key questions or issues that are not being prioritized or discussed that we should be focused on? And I have you in order on my screen, so I'm going to start with Dr. Salas Ramirez.
Oh, so many questions and so little answers. I think one of the things that I've been thinking about is how can we best prioritize the reopening schools for vulnerable populations, and what sort of policies are in place in order to protect those vulnerable populations. So a lot of the things that I hear from parents is, I'm an essential worker, or I've already been asked to go back to work. What am I going to do with my kid? And so it's sort of like this pressure of like, I need childcare, more so than I need to send them back to school. And school has kind of become that. Unfortunately, our teachers are not childcare providers. We do know that roughly 10% of our teachers have already requested medical accommodations. The Department of Education has yet to let us know exactly what the platform is going to be for remote learning if we choose full-time remote learning. There's a whole concept of pods, and I think Mayor de Blasio is actually talking about classrooms as pods. If we're talking about middle schoolers and high schoolers that are moving from pod to pod, they're being exposed to more than the set of like 10 or 12 children that they're supposed to be exposed to during the day. About a third of childcare centers that were opened a couple of months ago have closed since then because of an increase of COVID cases. And so again, all of this to say is that we really have to think holistically about what sorts of things are needed to open schools safely. And then once we figure that out, figure out how to accommodate our most vulnerable populations. So our children of essential workers, our English language learners, and our children with IEPs, which actually are also the most vulnerable in terms of contracting COVID. There have been several studies that have shown that children with learning differences have contracted COVID at a higher rate and have a higher mortality rate. And so we have to think about those things when thinking about school reopening.
Thank you, Dr. Salas Ramirez. Next, I'd like to invite Dr. Cristina Gonzalez to give us your remaining thoughts.
I think the one factor that you mentioned, one that may not be getting talked about enough, if I can answer that part, is thinking about the structural determinants of health, right? And I mentioned earlier, and I want to be clear that there's nothing wrong with people of color, that we're not getting sick more often and dying more often from COVID because there's something wrong with it. Somebody asked in the question in the chat. It's not just poverty. So people of color who are experiencing poverty have the double stressors. White people who are experiencing poverty are more often in mixed neighborhoods, so they're not in segregation. They're not having, the effects of segregation. And so they have more resources available, better education, better healthcare. And people of color who are not experiencing poverty also still have the stress of the stresses associated with systemic racism and sometimes interpersonal racism. And so and that varies by individual. So it's not an all or nothing. And I just wanted to be, but it is the two compound. And so I just wanted to make that clear on the Q&A, that it's not because we're people of color. And so the last thing that I'll leave us with is that, as I mentioned earlier, prevention is key. We have no medicine, there's no cure, there's not a vaccine yet. People die in ways that I never want to see again. Right? The death is horrible, the long-term sickness is horrible. And so prevention is key, but plan for a surge. Let's not be surprised in the fall, right? And again, it's not, as Dr. Ompad also emphasized, it's not just the DOE, all the city, the institutions, the state, we have to plan for a surge. And if we plan for a surge and it doesn't come, then great. But if we plan for a surge when it comes and we're prepared and we save lives, wouldn't that be the best outcomes to save preventable deaths from occurring that we weren't able to prevent in the spring?
Thank you, Dr. Gonzalez. Let's go to Dr. Gonzalez-Cruz next, and then we'll end with Dr. Ompad.
Yeah, so my final thoughts are that for parents to be educated about where they're going to send the students, and knowing the fact that not all schools are being designed and built the same. Every school is different, and collectively with the school districts or the Department of Education to make that honest decision whether the school really can handle in a safe way the student. If it's not, then don't push it beyond and put the students at risk. And that will be the case in many schools, but also there are many schools that can handle this if they're properly upgraded and updated, and that information is being shared with the parents, so that confidence and trust is built, and that information is being shared as the school year progresses altogether. So there are some hopes, and we have to be honest and be also curious about the environment that we're sending our children.
Okay, so I have three kind of quick points, and I promise to make them quick. The first one is that COVID is in charge. The epidemic curve and the number of cases is what is going to drive, what should drive, to be clear, not necessarily what does drive all decisions. So for now, cases in New York City are coming down for the most part. We haven't seen any deaths for 3 days. Should we continue to see that, then it's probably a lot safer for your kids to go to school than it was in March. However, August and September, what happens? College and university students start coming back to New York or come to New York for the first time to go to school. They're coming from those states where they have increasing cases and different approaches, shall we say, to masking and social distancing. We are asking them to quarantine for 2 weeks, but we know how that kind of goes with adolescents and young adults. So our epidemic curve could change at any minute. And so we need to keep that in mind, and we have to be nimble when we're thinking about planning. The second point I'll make is that there are a lot of competing priorities here, right? So there is the priority of keeping your children safe. There's the priority of making sure that your kids have the optimal learning environment, and that's both academic learning and social emotional learning. It's also making sure that parents can go to work to provide food and shelter for their children, and that the economy can get back on its feet. So there are no easy answers to this situation, and the fact that we're struggling is really indicative of an unprecedented situation. And the last point I'll leave you with, which I've already alluded to, that the situation is going to change. How it's going to change, we don't know, but you should be prepared for the idea that things are going to change, whether it's the number of cases, hospitalizations, or deaths, whether we get a new vaccine, whether we get new information about what, we don't even know if infection confers immunity right now. We don't know if there's long-lasting immunity. So information is going to change, which I know makes people really anxious, right? Like, we want to know what we want to know. We want to know the facts. And I will tell you that the facts are evolving, not from anything other than it takes a lot of science to get those facts to you. And 8 months and 1 week is not a long period of time. So I do think that most people are working as hard as they can to get the answers we need to make the best decisions, but it does take time. And you're going to have to be patient with epidemiologists, neuroscientists, physicians, biostatisticians, all the experts that you see on TV. We're giving you what we know is the truth at this moment, but that truth can shift as we get more data. So those are just kind of the parting thoughts I'd like to leave you with.
Thank you so much. If we were in person, I would ask for applause at this moment, but I will just applaud you and thank you. We have, this took longer than I was expecting, but it was such a rich discussion, and I think everyone learned so much. I certainly learned so much. So we're going to go through some questions in the next 10 minutes or so, and we're going to try to do it like rapid fire. So if we can just try to answer the questions really briefly. So the first question is, obviously we have different rates right now in different boroughs. Staten Island and Bronx are higher than 3%, I believe, right now. So how does this weigh into the risks for parents and families, especially for high schoolers who travel? Dr. Ompad, why don't you take this one?
Sure. So the more people who are positive and can potentially transmit that are out in the community, the more likely you are to come in contact with somebody who is able to transmit. So basically, the higher the prevalence, up until about, maybe we think herd immunity will happen around 75–80% infected and immune, you run the risk of infection. So we want to keep those prevalence estimates down as low as possible before we open things up. So there are implications, like there not being a person who has gone to school in New York City, I have come to realize that kids don't go to school in their neighborhoods all the time, especially for middle school and high school. So when you're thinking about communities and schools, you have to think about the community where the school is and the community where the kids are coming from. So it is good. Like I said, these are not easy decisions. And so it's going to take some real thought from school administrators as well as parents about whether or not it's safe for their kid to go to school, either because they may have been exposed and they may expose their classmates, or their classmates may have been exposed and could expose them.
Great, thank you. There are quite a few questions about bathrooms. Sharing bathrooms, the possibility for fomites to be in the air from flushing, small bathrooms without ventilation that are shared. Who would like to chime in on the risks here with shared bathrooms and poor ventilation that are coming in on the chat? A very real issue. Maybe our air expert, Dr. Gonzalez Cruz.
Yeah, so in terms of the bathroom, we have given a lot of thoughts about these too. And I think that the rules, the common sense that will apply here is to, of course, wear masks, minimize time, and also density. So the school can limit the number of students that can use the bathroom at the same time. That will resolve a lot of problems. I think most of my colleagues will in this field will agree on it. And bathroom can be ventilated. A lot of the schools are designed to have proper ventilation. That needs to be again checked. And then of course proper hygiene prior and after leaving the bathroom. But I think density is a key variable here, is to minimize the number of students or staff that are using the bathroom at the same time. So putting limiting the capacity to it, and those there are standards to determine what will be a reasonable number under this condition, which means increasing the or decreasing the level of exposure.
Thank you, Dr. Gonzalez Cruz. We're moving along. This one I'm going to punt to Dr. Salas Ramirez. It's a science and a developmental question, and it's a two-part question. The first is, do we know what masks are effective for young children? And secondly, in terms of your, referring back to some of your earlier comments, there's some questions on the chat about face shields or masks that are transparent that show the face, and what is the potential for those to be used in school? And then just to add another one, sorry, is there any research that we know on the benefits of live remote, fully live remote versus hybrid and remote? Thank you.
Yeah, so just with everything, we're still learning. I mean, we are just learning about screen time and how screens can really affect the development of children. It is recommended, particularly for young children, for them not to be on the screen in terms of in that instructional time for longer than 30 minutes. And the older that they get, the time increments a little bit more, but definitely even for high schoolers, you don't want them to be in front of the screen with instruction for more than 2 hours. And we know that some schools have had very different expectations in terms of how children are engaging with their screens, but it is very developmentally dependent. The younger they are, the less time you want. In terms of the masks, again, very limited understanding in terms of what the best masks are. For now, surgical masks are definitely effective in terms of children. There doesn't seem to be any significant benefit with children to have the one with the little filter, right? There's a little knob. There are some masks that do have screens, right? Initially, they were created with the plexiglass clear screen for deaf people so that they could read lips. I go back to, even if you have a little screen here, you still have facial musculature that children will not have access to with the continued covering. And to add a layer of that, the Department of Education does not have the money to purchase these masks. So currently, as it stands, the Department of Education has 1 month of PPE purchased for all schools. Beyond that, we currently do not have the means to purchase more. So the Department of Education is looking for ways to continue to purchase the PPE, because it is going to come from the central from central contracts and not from school budgets. But that's still people are still having conversations about that, about how we're going to alleviate those costs. So in summary, that's about as much as we can say right now.
Thanks, Dr. Salas Ramirez. And then the question on whether there's any research indicating that this blended model is preferable to live remote.
Right. So again, the blended, if we're thinking about this blended model, there are some students that have been responsive to the remote learning. We do have to also understand that schools police certain children, and there are children that have had experience with bullying, being over policed by security agents. The bullying doesn't always happen with peers. It could also be happening with through their teachers. So we do have some trauma that is inflicted in children, particularly Black and Brown children in school. So we do have to keep that in mind, that remote learning was not detrimental to everybody. It was actually beneficial for some children. The blended learning model as it is being presented right now, again, we have to look at all of these different factors. We have to look at the fact that the children are going into school with the 6 feet social distancing and not having contact with each other. If it were a choice that some children are more responsive to the remote learning for half of the week, and that's just how they learn better, and still are able to engage in a developmentally appropriate fashion when they're in school, this could work. But that's not what's happening. We are limiting their developmental social interactions in a way that could be we could be re-traumatizing them. And so although we don't have the research fully to understand it under the current variables, right now my questions are definitely geared towards, are we engaging in developmentally appropriate practices when engaging in this model of blended learning, versus if they were able to engage in a more holistic and health conscious way.
Thank you, Dr. Salas Ramirez. So we still have 120 people participating. We still have, I would say, around 200 people on the live stream, and we have many questions left in the chat. So I wanted to ask the panelists if we could go until 7:40, and then we'll close. And we're already getting requests for another webinar, but so if that's okay with you, you can give me your thumbs up. If you have to drop off, I will say thank you very much for your time. Dr. Cristina Gonzalez, I'm going to ask you one more question because I have a feeling you have to drop off. And that is, in Europe, a lot of families have been talking about how this has happened successfully in Europe in terms of reopening schools when there was a similarly low infection rate as in New York. And, you know, they've even kind of transitioned to reduce the restrictions of social distancing and so on. What is your perspective on this?
So I don't know, like intimately familiar with the details of what's happening in Europe, but from what I know broadly, I can say that the response in other countries has been very different than our response. There's been a centrally coordinated response. And so to my understanding, we are on the upswing still, right? Everybody was waiting for the second wave, but we've never ended the first wave. It's just never ended. And it's ended for other countries. It's ended very much successfully for other countries, right? I am thrilled that we have 3 days in a row of 0 deaths in New York, because I was working in the hospital when we had the 800s a day. It was awful. But it's not even anything I can say or not say. And if other panelists have more expertise on answering, by all means, please. I would say that it's not even like comparing apples and oranges, which are both fruit. It's like comparing an apple and like, I don't know what.
A car.
Yes, there you go. And I mean, no disrespect. It's just the what has gone into their response and their condition being the way that it is, even if you see them going back to school and doing okay, is not what we've done. And so it's impossible to make recommendations because the situations are so different.
I will just add that other countries have had more testing and more coordinated testing. Our testing, quite frankly, has been a hot mess. And the other thing is that some places are starting to see an uptick in cases and are thinking about rolling back their opening. Mm-hmm. So So again, when I said that situations changed and we have to be nimble and flexible to roll back as necessary, which, you know, for kids is really difficult. You get to go to school on the first day and 2 weeks later we have to go back home. I can imagine that's really frustrating for families and for kids. But again, we're not in charge right now. The virus is.
Thank you so much. Dr. Salas Ramirez, Dr. Cristina Gonzalez, I know you have to go. So we thank you so much for your incredible expertise. There is so much positive feedback coming from the chat. People have said this is the clearest summary and analysis of the research that they've seen. And I think this will be tremendously helpful. So thank you for that. Feel free to drop off. There are a couple more questions that Dr. Gonzalez Cruz is gonna take, and possibly Dr. Ompad, but we're gonna wrap in 5 minutes anyway. But thank you again. Bye. Okay. Dr. Gonzalez Cruz, there is a lot of questions about lunch. And Dr. Ompad, you might also want to weigh in on this. Children are going to be eating lunch indoors. What are your thoughts on this? And what are the risks here?
Yes, so thank you, Rashida. I saw some of these key questions on this topic, and again, having just a minimum, knowledge on how a HVAC system work will be useful here. So when we do design a dining room, it is being designed for higher ventilations already. So if the system is properly calibrated by professionals that the school district will hire, and their instrumentations to look into this, how to calibrate the ventilation in the different places, then that dining room will have some by design. So it will be an issue to bring it up to date. And again, they are in the proper filtration in that space. Typically, we design that space to be standalone. So asking the parent asking the question, have we been updated and upgraded our ventilation system, including the dining room? So that's the number one aspect, if possible, to reduce the distance between students, so maintaining the social distance. That will be the person-to-person transmission. That will clearly be very useful. And I'm sure that schools are thinking about that. The next question is, can transmission occur within the indoor spaces? If the system is being calibrated properly, it will respond adequately with the filtration that we talked about it before. So the ventilation for the classroom will be different than the dining room, and it will be different also for the bathroom by design. That's how the HVAC system was designed. The question is it working as it was designed?
And just a quick follow-up question there. So is it at all possible to put something in an old classroom that does not have a central HVAC system to filter the virus from the air?
Yeah, there is a portable alternative. So if there is no other option, there is a lab that is unique and the student do need that lab, for example, we can handle that situation on a case by case. Then in that case, we go from MERV 13 filtering to HEPA filtering coupled to fan systems. Again, keeping the social distance will be essential. So we can handle that situation. We have done that in the past for other events in some of the lab. That will be a likely scenario for unique laboratories that the students will have no option in using that equipment that's supposed to go to a different classroom because it's not properly equipped. There was a question also on this about all school or all buildings, which beautiful historical buildings. A lot of these buildings have been retrofitted, but that may not be the case. So again, we need to ask the question, is our building properly ventilated with more modern equipment so it can handle the challenge or no? But the fact that the building is historically 100-year-old doesn't mean that it doesn't have adequate ventilation. It was most likely that it will have adequate ventilation because it's been retrofitted over the past number of years.
Well, it's 7:40. I want to give Dr. Salas Ramirez once again and Dr. Ompad once again a moment to give a brief, closing remark. I know we've all been monitoring the Q&A, and I promised we would only go over 10 minutes. We still have a captive audience. I feel like we could spend an entire day talking about each of these issues, ventilation, health disparities, so on and so forth. But let's have a quick closing remark and then we'll close the panel.
Dr. Gonzalez Cruz mentioned that one of our options is outside learning. So I do want to put in a little bit of a plug for schools to consider outside learning. There are conversations that are occurring across the city, and I know the Department of Education is also having those conversations. I do not think outside learning should be for the 5.5-hour days, but we could consider having outside learning for the same amount of time that we would have children, for example, in these pods, right? And so schools have to become creative in terms of how they're engaging students. I don't think it's realistic for having a 5.5-hour school day with children not engaging socially with the social distancing and the masks, etc. So there are a lot of things that we really need to rethink. We'll have a lot more information come next week once we have, once parents have filled out their surveys, and once we know the number of teachers that will be coming back to school. I think the Department of Education is thinking much more about how all of these different factors are going to play in. So this conversation is to be continued.
Thank you. Dr. Ompad?
I think the last thing I'll leave you with is, once you're off this webinar, where can you look for really good information? And I'm going to say that Dr. Fauci, who I call St. Anthony Fauci to my friends, is probably the best voice of reason. He is cautious. He will admit when he's wrong, or when he got it wrong based on the information he had at the time. And if he's telling us that schools are safe to open, then I would feel very confident that schools are safe to open. And if he's concerned based on certain parameters, then I would be concerned too. He is, no matter what station you watch him on, if it's Fox, it's CNN, it's BBC America, whatever the case may be, Dr. Fauci is my go-to source in the public realm for information on COVID.
Great. Well, with that, thank you so much to Dr. Cristina Gonzalez, who had to go on another call. That woman doesn't take a break, I guess. Dr. Salas Ramirez, Dr. Ompad, and Dr. Gonzalez Cruz. We really appreciate, as a parent of a young child, I learned so much. I appreciate your insight so much. And I know I speak for all of the participants. And to all of you participants, thank you. The recording will be made available. We will also have sound bites cut that you will see on social media and elsewhere. Thank you all so much. Be safe, take care, and best of luck come September.
Okay, thank you.
Thank you so much, Dr. Ompad.
Take care.